He's hopefully got all the answers for us on this. Paul Seegert's on the show with PCS Healthcare Advisors. They consult businesses all over the world, but mainly here in North America regarding prescription drugs and the like. Paul, good morning. How are you?
I'm doing great. How are you, Scott?
I'm doing fine. Good to have you back, buddy. Appreciate it. So there's 3 programs here. So let's get the overview. What does this do? What's it do for me? Let's put it that way.
Yep. The first thing that jumps right out at me when I look at these things is to see if they're limiting the cost of the drug or the copay. In this case, copay jumps out pretty quickly. Same as we saw with the cap on the insulin copays for those with Medicare that went into effect recently at $35. Mm-hmm. It didn't cap the overall cost of the drug. So then often what happens is it just pushes the balance of the cost into the insurance plan, or have to get covered by the insurance plan, not the member. And then the insurance plan has to increase premiums to account for the fact that they're covering a larger share of cost. Right. So it doesn't actually result in lower cost overall of the system. So I looked at this and I thought, okay, they have 3 ideas that have come out of the CMS Innovation Center as a result of this executive order. The first is a $2 drug list, Medicare $2 drug list. Mm-hmm. That's going to be for inexpensive things like statins and a bunch of other stuff that are really generic drugs.
Right. Which last time we talked, Amazon already jumped in that game, as Target and a bunch of others did, where they're offering unlimited prescriptions for $5 a month or whatever it was. So that's not a game changer.
Not a game changer. And Walmart came out with a $4 drug list, $5 drug list a very long time ago.
Yeah, right.
And so that's kind of, not new.
Okay, nothing there.
And it's not where a lot of the money happens in the drug business. I don't care what percentage of people take generics. It's really the small percentage that are in really expensive drugs that are blowing up the system.
Right,
but
right.
Those are going to be limited to $2. Same thing is potentially going to happen there. They're going to push the balance of the cost into Part D plans, which will drive up the premium Part D plans at the next renewal. The next one is cell and gene therapies. We've approved in this country 4 drugs, and we have a pipeline of more since August that are north of $2 million per person that gets prescribed the drugs. Now, they often are very significant, life-changing. You get the treatment once, you're cured, this kind of thing. So it's impressive and it's amazing, but it's very expensive. Okay. And so what this is going to do is encourage state Medicaid agencies to work with the manufacturers to say, we want access to these drugs, but we're only going to pay you when they work. More outcome type thing. So we'll see. And it's an encouragement. It's an opt-in program. It's not required.
That's like saying, isn't that kind of, Paul, like saying, hey, you know what? I'm not going to buy car insurance, but when I have an accident, then I'm going to buy the car insurance.
Yeah, it's kind of like that.
Good God.
And it's going to say, if you'll sell it to me. So it's a voluntary program. These are not, they're not going to go out and be able to, they can't go and require these manufacturers to do it. So they have to try and somehow entice them into agreeing to that. We'll see how it goes.
It doesn't sound promising. So far, 2 out of 3 is horrible. Well, give me the last one. Maybe the last one is a gem. I'm hoping. Fingers crossed.
The last one. Think back to Aduhelm, that drug that was approved for Alzheimer's that had no evidence of clinical benefit, but was going to cost $100,000 a person all in. This one it's addressing things like that. So it's the accelerating clinical evidence model where when you have a drug that gets approved quickly under accelerated approval, but doesn't have confirmed clinical benefit, what they're going to try and do is say, hey, we'll approve more of these that don't actually have any proven benefit. We'll pay you less until you prove it as benefit. Is kind of the layman's explanation of that one. Okay. That one, I think drug companies might say, sure, that sounds kind of good. So I don't have to, even if I have something that hasn't been shown to prove any benefit, I can start to generate some revenue while I continue to prove it out. So that one might have some value.
Maybe. So this basically was just saying, hey, look what we're doing for people. We're not really doing anything. We're just moving sand from pile A to pile B and then pile B back to pile A again. But you get credit for it, and hopefully this gets you reelected, right?
Yeah, exactly. And when you look at what they did with the Medicare, the drug pricing, Medicare is going to negotiate its own pricing deal. Last year, it was part of the Inflation Reduction Act. So those handful of drugs that haven't kicked in yet, it's already having an impact on our system. New drugs that are being released at higher prices than they might have been released because they're already padding They're already accounting for the reduction in revenue on certain drugs.
Yeah, and of course the costs will get passed on to those with private healthcare insurance, and we're playing that game again, right? Paul Seegert, PCS Healthcare Advisors, on the president's executive order to introduce not one, not two, but 3 different programs to help lower the cost of drugs, prescription drugs, which 2 of the 3 are already being done. The third one doesn't sound like it's going to do anything except increase costs. So I would say 0 for 3 on this thing. If you were omnipotent Paul Seegert and said, okay, and you were handed the keys to this and the CMS Innovation Center, I'm not quite sure what that is, and said, Paul, you come up with, what would you do to lower prescription drugs?
Oh, to me, it actually would be so easy if we didn't have 15 lobbyists per every member of Congress protecting all of this money. You would require transparency. This is the role of government. Create guardrails so that free market can perform. We don't have a free market right now because we don't have transparent pricing on anything when it comes to this stuff. If all the pharmacy benefit managers who don't make drugs, who do not wholesale drugs, who do not retail drugs, but control drugs and access to drugs, control formularies, and what people can get through their insurance, if they all had to, first of all, they shouldn't be owned by insurers, which most of them are now.
Yeah.
They should be operating separately, and they should compete transparently for the business of running the drug benefit plan for the various insurers, private, public, et cetera. And they should be competing like everybody else does on cost and quality. So what we have now is they source a drug for $5. They secretly mark it up to some other unknown amount that gets sold to the health plan. All the health plan knows is what it pays. It doesn't know what they sourced it for. It doesn't know how much the rebates are attached to it and all the various other games that get played that inflate the cost. It could be 60% of the drug transaction after the manufacturer, wholesaler, and retailer is added as waste by this pharmacy benefit manager today. That could be the case with a given transaction. We should know that. And if it was public, transparent, and they had to compete on an annual basis for that business, then we'd watch it perform like an actual free market.
Yeah.
Costs would go down, quality would go up, and we wouldn't be paying 10x what our peer countries pay for things that we innovated.
So it's all the middleman, is what you're saying, and you totally get it. But and that is the model that's set up through lobbyists in Congress, is you have more and more levels of interference, bureaucracy, compliance, et cetera, et cetera. It just drives the cost up. You see this at your doctor's office. Look how many people work in a doctor's office. You got your physician, maybe you have an assistant, a nurse or two, but mainly most of the people behind the counter are there to either schedule or work on billing, right? Yeah,
you have this 80-20 rule, and unfortunately 80 of them are dealing with the non-providing of care roles because of all the stuff that we put them through.
Yeah, my physician I love the guy, retired, and he finally found somewhere where it was okay. I spent more time. He said he'd get in 5 a.m. and leave most days at 7 p.m. And all of it was follow-up. And a great care provider, but the guy was burnt out. And I get it, right? It's because of all the compliance, all the hoops you got to jump through in order to satisfy all of these government whims. And yeah, we have to have oversight and control to be sure. But my God, it's just so complex right now. And is that also part of the reason why we're seeing so many people leaving or not getting into the profession of medicine?
Absolutely. Burnout because of all this stuff. Look, we're on track for, depending on who you believe, a shortage of 450,000, 500,000 nurses. And it ties into the same thing. They got into to do nursing, and they're doing a lot of other things in addition to that, and they're in an understaffed environment, and that's not a life that you want to live. It's anecdotal, but the people I know in the business are not encouraging their children to go into it.
Yeah, we're seeing just record numbers of people. And if you go into it, it's going to be in a specialty, right, where you can make a lot of money to offset that heartache. This is why we're not having enough healthcare providers and clinics and pediatricians and things like that. There's not as much money, right?
Yeah, exactly. And they're getting less over time. So you have the programs come out, the Medicaids, the Medicares, that are a lot of the now control more than half of the payments that are going out. 51% of us are getting our health care from the government today. And so they show up at this provider's office and they're going to get less for that visit. They may get less for that visit this year than they did last year.
Yeah.
So it's squeezing them.
Right. Paul Seegert's PC Healthcare Advisors here. He consults businesses regarding keeping their health costs down. And President Biden, with an executive order, 3 new programs to help reduce patients' out-of-pocket costs relative to prescription drugs. And anytime you hear 3 new government programs to reduce something, it's the exact opposite, probably. It's just going to increase the mess and what we have to pay to as well. And this is adding to the crisis in hospitals and clinics, doctors' offices where you don't have enough staff because, compliance burnout. The more laws you create, the more compliance there is, and the less health care you're actually providing. It has to do with more with administration and administrative costs than anything. It's driving a lot of good people out of health care. Another great example of it. We need less interference from government, and not more in the eyes of, under the edges of it's going to help you. The one thing that you struck me, you're talking about nurses quitting in huge numbers, Paul Seegert, and that is the traveling nurse phenomenon now. My mom, when she had cancer, was getting treated by a visiting nurse. It was wonderful. But why is that such a big thing right now? Is that basically a keep the cost down perspective from the hospital, where they don't have to have an employee? What's going on there?
Well, no, it's having the opposite impact because the cost of a traveling nurse is wildly higher than a resident nurse. So it used to be they would get $1,900 a week as a traveling nurse, and it was just a person that enjoyed that lifestyle, and it wasn't necessarily a ton more money than the other options. Now it could be $5,000 a week and a big signing bonus and so on. I mean, I'm doing business travel and flying out today, and I expect I'll be sitting in a hotel, restaurant, bar with a bunch of traveling nurses like I did last time. But the hospital, it's driving up costs for the system. So that's because there's a shortage, it's a supply and demand issue.
Gotcha.
They're pulling nurses away from rural places, urban places, lower income places, and those places are having to shut down some of their, you have rural hospitals shutting down maternity wards because they can't staff them. Even if they do have the money to staff them, they can't staff them because the nurses are on a plane flying somewhere else into an urban area and getting paid a bunch more to be a traveling nurse somewhere. But that's also contributes to why we had 53% of our hospitals that posted a loss last year. Yeah. Their costs are getting driven up, not only by inflation, but by labor and by so many factors.
Good if you're a nurse, right? You just basically become an independent contractor.
Yeah. And now we are seeing some of this revert back because who really wants to be, maybe, do that for a period of time, put some money away, but you really want to live that way forever. And so we are seeing some health systems that are actively reaching back out to all the people that left from burnout, from vaccine mandates, from all the things that occurred in the last couple of years, and they're getting 1 out of 4 to come back.
The problem, too, though, it's a demographic one, right? So we have all of these elderly baby boomers, right? Because baby boomers in the heart of that retirement demographic, the bubble, right? And there's not enough people behind them to support that. That's essentially the model. When that fades out, once the baby boomers head into extinction, and we all head into extinction, right? We all die someday, and our cohort now, being a Gen Xer, I'll be the oldest one, I'll die, and then we have the millennials and then generations behind them, the Zs, right? And whatever comes after that. So in that regard, too, if now we become a smaller number of people who are retired and graying of America, eventually in 20 years it's going to dwindle out. What then? Does it fix itself? Because now you've got a lot more workers, presumably, for fewer retirees, and it goes back to the way it used to be?
That certainly will help things. The math will work a lot better. But I think we can solve it. This is America. We can do this. We innovate, we create, we solve problems after we try everything that doesn't work first and lobby ourselves nearly to death. But we can do it. There's examples in our system of success happening right now in how we pay for healthcare. The systems across the pond that are, National Health Service in England, they are imploding. It's a 90-minute wait. If you have a heart attack or stroke right now, it's a 90-minute wait. People are dying waiting. And that is a real thing. It's not fear-mongering. It doesn't work that way very well either. Rationing care is not effective, and lying by price in the way that we're doing it, where it's not truly free market and you don't have transparency, isn't working that great. But we can fix it. You look at all the things that people access in our system without insurance. And how well those are doing. The cost of dental implants goes down and the quality goes up because they have to compete and become more efficient and do what a free market person does. Same thing with elective procedures of all kinds. Cost goes down, quality goes up. We have examples of the system of how to do a better job. Look at managed care organizations that, like Medicare Advantage. There's good and there's bad. Now, like every American, I'm glad when that season is over and I don't have to see those commercials anymore. but the fact that they can take a certain amount of capitated dollars and provide healthcare to a population and have money left over to give them other bells and whistles when the traditional Medicare can't, tells you something.
Yeah,
there are better ways to do that.
Yeah, and you're 100% right about that too. Paul Seegert from PCS Healthcare Advisors on the Scott Sloan Show on 700 WLW. The rationing of care. I was over in England this summer, and one of the big stories when I was over there was an elderly man who had fallen off his front porch, and it took I think it was raining, and so the neighbors covered him with tarps for a couple hours until the ambulance got there. Right. A couple hours. Yeah. Can you imagine the outrage in America if that happened here?
Yeah. Yeah, it wouldn't even happen. No way.
Yeah.
And they're waiting months, literally months for life-saving therapies for cancer, et cetera. And while people, unfortunately perish or it gets worse.
Mm-hmm.
I mean, it's not sustainable in that form. Any system where, the only solution is going to include transparency around cost and competition. We have to have those things.
Yep.
Or we're not going to get there. We're just going to watch this continue to eat up more and more of our GDP.
Mm-hmm. And you hear people talk about how great the healthcare. Why don't we just be more like Europe? Well, if if there's an injury, if I need a broken arm, something like that, trauma care is great. It's there's no payment. It's awesome. But if you have something chronic and long term, man, good luck with that. Paul Seegert, PCS Healthcare Advisors. I know you got to catch a flight and all. Paul, thanks so much for the time.